Okay, good evening to everyone. Dobre utre, dobre večer. It's really a big pleasure for me to give another webinar at the OHIS World, and with the topic that has been asked to me to talk about, which is aligner treatment in early dentition, managing the three dimension. I will during this talk, I will give you my view based also not on clinical evidence, but also on scientific evidence on treating a patient with aligner in early dentition, which is one of the most exciting topics that we have today in our community. And I will try to go deeply on how and with which tools we can handle this kind of treatment in young patient, very early patient. So I'm starting with this article that has been published back in 2016 on the Anglo Orthodontist regarding the children perception of the smile aesthetics and their influence on social judgment. And one aspect that we have to take in mind in this era is that we have a social media aspect that we have to not underestimate, which is bullying and victimization. And so we know that boys can have a face-to-face victimization and girls can undercome cyberbullying victimization. And we have seen many episodes of these two aspects. And regarding to this, we have to consider aligners as a potential part of the life of these young patients, especially teenagers, because we know that aligners are virtually invisible, they're smooth, comfortable, and they are removable, so no problem with food. So these are some of the aspects that can bring us as orthodontists also to provide to patient who has or young patient or teenager patient or kids that has a malocclusion which can create an issue, having a solution that could avoid this kind of victimization and bullying on them. And if we consider on the other hand the periodontal advantages and health in teenagers treated with a removable appliance, combined or making a comparison with fixed appliance, I take this article published on the Journal of Orofacial Orthopedics, published in 2015, and we know that aligners, treatment with aligners are less caries sensitive than fixed appliance. And so the conclusion of this article stating that teenagers treated with the removable appliance display better compliance with oral hygiene, less plaque, and fewer gingival inflammatory reaction than the peers with fixed appliance. And more, having me a personal experience with aligners that started in 2001 and now is almost 20 years. I started my first case with aligners, while 20 years ago was I could be considered a crazy orthodontist thinking to move teeth with plastic. Now it became mainstream in the last, I would say, 10 years. So I struggled like everyone when you struggle when you study something new. But of course, I took the advantages of this early struggling to appreciate what also the manufacturer has given to us as new tools in combination and in association with the conventional orthodontic where I still do in my practice, because I still doing braces and wires in scenario, for example, when the patient is not willing to comply. So we have to always to consider that brackets and wire is still a very valid tool, but it's also is evident that in the past we did not have any other option. So in that sense, having a removable device that allow patient to have a better periodontal health is a good point in favor of aligners. So which dimensions I will consider in this talk? The transversal, the sagittal, and the vertical. These are the three main dimension I have to consider. And if I will add another dimension is the fourth dimension, which is compliance of our patient treated with aligners. So these are three clinical dimensions that I will go through during this talk. But also don't forget the fourth dimension that during already the first visit, but also during consultation with patient and parents will be clear also as your decision as clinician if you could use aligners or not, apart from the clinical efficiency based on the virtual simulation, but based on the patient, which is fundamental as an actor of the whole treatment. So, talking about maxillary expansion with aligners in early dentition, this has been a topic, it is a topic very popular in the last few years, especially because in the last few years we have had more and more application of aligners in early dentition. Of course, starting as the American Association is telling us that, for example, the first visit should be at age 7, and at least in Europe or here in Italy, we have the parents bringing out the kids, both females and males, the very early stages. So at least when you have at least the upper 4 incisors, permanent, upper and lower, and the first permanent molars, there are scenarios where, in a phase 1, for example, the use of an orthodontic appliance could be useful to prevent more, let's say, complex scenario to handle on a later stage. And in terms of topic I will cover in this regarding maxillary expansion, we know that we have causes of maxillary constriction, and we have timings that we can use to treat the patient when we have maxillary expansion as one of the solution. I will go through some clinical cases, and also I will give you some research data on why, for example, Invisalign First could be an alternative to the conventional orthodontic appliance used usually to expand. For example, an expander. The expander is probably the most used orthodontic appliance in the orthodontic community at the early stage. But there are alternatives. As 20 years ago, we only had metal, either buccal, either lingual. Then it came out the third player, aligners, so in adults. But then from adults, we went through teenagers and also we went through kids. And so the first aspect I have to consider is causes of maxillary constriction and timings. So in terms of causes, already in 1985, there was an article telling us that there was a correlation between mouth breathing, occlusion, and modernization in a North Indian population. So human societies undergoing rapid modernization and acculturation show an increase in both allergy and asthma, but also in malocclusion. So these are aspects that already 30 years ago almost was evident. And if I go after almost 20 years, this article published on the Anglo Orthodontist in 2006 was making a study on Italian children born in the 50s and in the 90s. So Italian children born in the 90s show a significantly reduced transverse intermolar maxillary width, higher in comparison to those children born in 1950. So contemporary children have a greater probability for developing a malocclusion compared with the children living 30 years before. So, and this is part of the, I would say, the acculturation and the modernization of human societies. And we also know by papers written by Jim McNamara many years ago, so in the almost 60s, that in causes, we know that subjects with dental crowding were more likely to have a smaller dental arch measurement than subjects with no or little dental crowding. So subjects with crowded dental arches could not be distinguished statistically from subjects with normal occlusion on the basis of tooth size. And in terms of timings, also Ricketts and others reported that transverse growth changes occur from age 9 to 16 for both genders, and with an increase from 62 to 66 millimeters, so 0.6 millimeter per year. And also later studies by Ricketts and Gramos, but also McNamara and Brudon reported that gender combines transpalatal width increased only 2.6 millimeter from age 7 to age 15. So that's why the intervention of the orthodontist could be very useful to increase that width that will allow, especially in severe crowded case, to have enough room to get space for our permanent dentition. So these are aspects from the literature, very helpful for us as orthodontists to make to understand causes, but also to get the timing and knowing that the transverse growth of the face is near completed by age 18 years, although nasal width still show growth increments. And also, de Klerk and Profit on a more recent publication published in 2015 was stating that in young children up to age 8 or 9, little force is needed. We don't need the great forces at that age. The bone is still not that solid as we have in adult patients or in a mature teenagers. So up to that age, just a transpalatal lingual arch for dental expansion will be enough to open the mid-palatal suture. So the thought we had in mind is if it's needed so less force at that age, could we use another kind of appliance to solve that kind of issue as an orthodontic issue? That's a guessing point we all should have. So I spoke about maxillary constriction causes and timing. I will show you some clinical cases, and also I will talk about research data. And we know that between early treatment and treatment in one phase, there is always a big debate. It has been in the last 50 years, and it will continue in the next 34 years. That's part of the nice of our profession. And already we know that from this article published in 2016, that early treatment reduced the complexity of malocclusion. So we know that there are some scenarios in which early treatment, for example, in class 2 division 1, could reduce the risk of incisal trauma on those kind of patients. And I still recap this article published in a few years ago on the Angle Orthodontist, that children born in the 90s show a reduced transverse intermolar maxillary width, a tendency to a reduction of the posterior transversal intermolar discrepancy if compared to the same patient age in the 50s. So we have to consider the era. So the guess is, could we use aligners in early stage? So think about the treatment of a wide series of malocclusion with the aligners. Dental arch expansion, I will show you later on, is a predictable movement. Of course, we need to have a support of short clinical crowns. And we have features treated with aligners that allows us to overcome a potential issue. We have support for the eruption of permanent teeth with a specific feature such as eruption compensator. And also we have a support for a prescription and planning for a phase 1 treatment. We're always talking about aesthetics, at least in the past. We were so focused on aesthetics and appliance in mature patient, and we mainly were missing these Gen Z patient. But if we think about Gen Z patient are those who are so focused now, especially those born between 1996 and 2012, which are the future generation of patient in our practices. So in which scenarios? Primary application, arch form development, creation and maintenance of space for teeth interruption, and then common condition includes, among others, arch form development, expansion, spacing crowding, AP correction, aesthetic alignment, dental protrusion or interference. And there are some features specific considering Invisalign first, in which we have expansion, which is a dental arch predictable, and where we have specific features like staging model improved, so first staging model for molar movement predefined, or a simultaneous staging. And I went through a pilot study in which we have only one option at the beginning, where we have the first permanent molar expanding first, followed by the deciduous teeth. And we can then later on align, Invisalign has embedded a simultaneous staging. we have specific attachment, specific optimized attachment for support for expansion, and we also have a specific smart stage technology to make sure we have a tooth movement as efficient as we have in teenagers and adults. So in staging options, we have two models of staging for dental expansion. So a first staging model for molar movement. So molar move first, followed by simultaneous expansion of canine and all posterior teeth, which is predefined. But you can ask a model of simultaneous staging. If you ask me what is your favorite protocol, Dr. Garino, my favorite protocol is the one with which I started my experience with alliance in kids, in which molars move first, the permanent, followed by the simultaneous expansion of canines and all posterior teeth. And we have a specific optimized attachment in those scenarios where we have short clinical crown, and these are customized and placed by the technician in order to make sure we have more grip when we have to support that amount of that type of transversal movement. And we also have, I don't want to go too deep on that, but we also have a smart stage technology applied to a staging model, new and improved. So this has as aim to maximize the efficacy of treatment, providing contact and force that whole tooth movement needed to expand arches. And we have those specific retention attachment as a support for short clinical crown. As I told you earlier, we have some specific eruption compensators which are represent a support for eruption of permanent dentition in scenario where we decide to start the treatment where we have only the two central permanent incisors and we don't have yet the lateral incisor present, but we want to, for example, expand in a crossbite scenario. So in that sense, these eruption compensators are specifically made to create a virtual geometry, allowing to have enough space to have the lateral incisor erupting inside the aligner, and then once erupted to evaluate if we need to rotate it or not. And this is something that Mother Nature will show us later on during the time. And quoting one of the biggest experts in orthodontic treatment in early patient, and I think that Marco Rosa is part of the speaker of this company. Marco Rosa was saying that the rationale of early treatment is an early mixed dentition consists in a generate space enough for the spontaneous alignment of upper permanent lateral incisor before the complete eruption. And this was a statement already done in 2016. So he's one of the masters of treating patients with orthodontics. And I don't want to go deep on brackets or aligners, but don't forget that the tooth is stupid. He doesn't know, she doesn't know if this is moved by a piece of plastic or by a piece of metal. So, but the rationale is to intervene on an early stage. For example, Viola, at 9 years old, she came to our office and already starting to show you some cases because it's important to create a fundamental, the basis of the building before showing some cases and application. Viola came at the first visit. As you see, she got 12, not yet erupted, but she got a crossbite on the left quadrant, the second quadrant, with an ugly duck syndrome of the 22. You see that with the lateral incisor, which was already tilted, probably due to the presence of the permanent canine, which has his tip going close to the root of the lateral incisor. And in that scenario, you see that after 7 months, we were able to handle the crossbite she got on the left quadrant with a liner. The case at this stage was not completed, but just to show you that within 7 months, we could handle that transversal issue with another appliance, which was not the conventional expander. And it's important to see every time you planning in virtual, that's one of the most rewarding scenario, that everything you do in virtual, it happens in the clinical reality. So many users of aligners believe that the big issue today is not the appliance, but the orthodontist. Those who still think that a virtual plan is done by someone else, but without any control. No, that's exactly the opposite. A virtual plan reflects skills of a good orthodontist. So if you're not a good orthodontist, you will make a crappy plan. If you are a good orthodontist and you dedicate yourself on doing a plan and then reevaluate critically the plan, this is what you will get if you are good on planning. And that's also what changes between conventional orthodontic and aligner orthodontics, where with fixed, you react every appointment towards a general plan. With aligners, you have to be much more proactive, so to plan upfront all your strategy inside this virtual basket. Of course, you can modify if you see that something is not working, and that's the work of a highly skilled orthodontist to make sure that if he or she see an issue, have to adapt their game plan to the issue that comes out. And you see that Viola, at the end of phase one, she got the crossbite corrected. It was not a long phase one, because here, one of the main goal was to create some space mesial to the upper deciduous canine in order to have enough room for the eruption of the permanent teeth later on. So also the orthodontic experience, excuse me, of a patient like Viola has to be focused on not a huge time. And I think that they deserve at that age to have the same ideal orthodontic experience as the adults, even more. So if we talk about the early treatment for expansion, quoting Patrick Fleming, who published it in 2017, there are the timing, the weight of evidence point to reserving early treatment for localized problem and specific situation with definite treatment. So it's always a question of timing. In a case like Viola, I could have said to myself, I don't do anything. But what would happen if I have to treat that crossbite when she is 15, 16, or 17? Much more probably complex scenario to handle, and not anymore a different bone density, a different dentition. So, if, for example, if I quote also this article by Marco Rosa about anterior open bite mixed dentition, these are the scenario where to intervene early could prevent the more complex scenario on a later stage. So imagine that this young girl come to your practice, and the parents bring Aurora with your practice, and you see a crossbite, a class 2 in a mixed dentition. What you will do? Don't do anything? Probably no. You will do something. Not talking about the appliance, but talking about starting or postponing. A scenario like this, I will never postpone, because if I have a dental crossbite like this one at age 8, and when I saw Aurora at age 8, that's a crossbite family, because the father has a crossbite, the mother has a crossbite, the other brother has a crossbite, the whole family is the cross family, I would say. And I said to the mother, issues here are two. We have not only the transversal to correct, but also the sagittal to correct. Because you see that in the right side, we have a class 2 molar with the over eruption of the lower deciduous canine, and with the arch forming the upper arch, which is constricted, with the upper first permanent molar mesially rotated. And it's evident the incidence of an asymmetry, a dental asymmetry at this stage, that could evolve if not treated in a skeletal asymmetry. So looking at the panoramic X-ray of Aurora, you see that she was a mixed dentition with all permanent teeth present, so there were no missing teeth, already with the germs of the upper and lower third molar present. And looking at the lateral X-ray with all the numbers from the SEP, skeletally, we had skeletal class 2 based on the hypogonium, skeletal class 1 in terms of A and B, and with a class 2 molar relationship. So the ClinCheck plan for Aurora was forecasting what? Was forecasting the transversal correction. You see that I added a button cutout, not only on the 16, but also on the 46, to reinforce that transversal action. And this case allowed me to learn from this kind of appliance. This was one of the first beta cases I started. And as a North Italian orthodontist, usually I'm not to be too brave. I'm very pragmatic. So I usually don't overcorrect too much. But I learned from this case that in case of transversal issue, it's better to overcorrect the transversal in order not to have even more aligners to ask later on. But you learn. It's always a question of how much you want to evolve your learning curve. And in terms of detail of virtual expansion, of course, this is the visual of how much you expand. If you ask me about numbers, typically in my transversal prescription, I do not expand in adult patient more than 2 millimeters per quadrant. In kids, I could expand quite safely up to 6 millimeters. So here I was not that much aggressive. You see that from the numbers I got from the beginning to the end, I had almost 4 millimeters of expansion, especially in the molar region. So during treatment, our main goal was to work on the transversal, not focusing on the sagittal, because I said to myself and to the parents, we will see how much we will correct transversal, and we see also how much will be the adaptation on the sagittal by the transversal change. And in virtual planning, you saw that I was not focused on the midlines because I didn't want to ask to center the midlines basing a virtual simulation asking me to correct transversal and then move in the midlines dentally. The risk was that I could even have the midline even more off if I was asking to the technician to move dentally the midline during a cross-bite correction of median and arch. So this is her after 6 months. And this was her before the additional. You see that in these stages, also before, she was then missing, exfoliating, a deciduous tooth. So here, this case is showing me that I could have been more aggressive in a transversal. In fact, what I did a new scan, I removed the attachment, and then I have a second set of aligners. Don't forget at this age, I'm changing aligner every week, sometimes every 5 days because of the bone density, which is totally different. And I tell you that this patient are the most compliant patient in the office. Young little girls are for me the best patient you could have on hand having a line if they are committed. But it's a role you need to have them committed if you involve in the treatment. Sometimes I have issues with mothers. They think that these young girls will not be compliant. You see that I asked more expansion and completed the rotation. And you see I have an eruption compensator on the 24 ear area and also another eruption compensator on the 34 area. If I look here in progress, look at what happened on the sagittal on the right side. I did not ask any distalization, but only through the transversal and the derotation of the 16, we have an improvement on the sagittal. I was ready to use an auxiliary, in this case, to correct the sagittal on the right side. But if you're looking at how she changed it before treatment and before the additional aligner stage, the scenario was changed quite considerably, at least in my hands, was not an easy case to handle with aligners a few years ago. And if you look at how changed the arch form in the upper and lower, especially in the upper, that's what was me a good outcome that I could have in my hands. And looking at how she was at the end of phase 1, so after 11 months of treatment, you see that transversally we got the goal accomplished. Sagittally, we got the goals accomplished. And also we have an improvement of the vertical. At that stage, I was not as eager to center the midlines because I said to myself, let's find room for the eruption of the canines and then upper and lower, and then see the whole exfoliation and see during eventual a short phase 2 how and where I need to center the midlines. But important at this stage was to correct the transversal and to correct the sagittal with a good intervegetation. And you see that before treatment, at the end of phase 1, We accomplished the two main goals we have in this case. And from this point and beyond, I said to the mother and to Aurora, from now on, you will be in the standby phase. Question that usually arise: what kind of appliance do you use in SACE as a stand, as a retainer? Do I leave a patient with retainer? Yes, I do. And you can use an appliance like Essex retainer, you can use a Holy retainer, you can use a AF relay appliance. There are many kind of devices. Important you leave teeth in control, especially transversally, and you see that the skeletal pattern hasn't changed in this page. We have a dental improvement quite important, and you see from the panoramic X-ray we have room for the permanent dentition to erupt. And if we look at the lateral X-ray, we didn't have a worsening of all the parameters. We have an improvement of the overjet and of the overbite. And I take the opportunity to share with you a study that together with my good friend Tommaso Castroflorio, who from our same city, we collected our cases. We gave, you see, we made a measurement on 43 consecutive cases because the goal we have, the guess we had was, is the transversal movement a typical movement or we have a transversal movement, a real an expansion? So as you can see, we have 43 consecutive cases, 21 males, 22 females with a mean age of 9.3. And the research data was showing we were looking for pre and post linear and volumetric measurement. We're using a student t-test. We made a morphological superimposition. This was not given to Align Technology, it was given to a private institution outside. And if you look here from the superimposition, we did not have only apposition on the buccal side, on the vestibular side of molds and bicuspid, but we also have a position on the area of the mid-palmar suture. And these are the data of the mean treatment time of these cases, the area increase, the volume increase, and this was telling us these superimposition was telling that it's not only tipping folks. So that was for us not a confirmation, but a good, let's say, feedback from a private site that we will publish it soon. There was a confirmation for us that at this age, we can have a really expansion movement going on. Of course, we will need to further investigate, but important is to see how efficient can be, as in Matilda, for example. Matilda came to our practice. You see that she got an anterior crossbite. You saw two cases of posterior crossbite. Here we have an anterior crossbite in a class 3 tendency with crowding in the upper and the lower. And you see from the panoramic X-ray we have to fight against space that we need to get in this patient with large volume of teeth. And that was a clean check plan. This was, as you can see, the panoramic X-ray we did before starting the treatment. So once we have the upper central incisor erupted at least 2/3, then we had the first clean check plan where you see we have short clinical crowns. At that stage, we did not have yet the minor attachment. The important here was to correct the transverse and to create the space mesial and distal to deciduous canine to allow to have enough room for the eruption of permanent teeth. And we did the same in the lower arch. So during treatment, this is Matilda, and this is her before addition line. You see that we already corrected the anterior crossbite, and we almost corrected the lower crowding. This patient wasn't a big cleaner, if I have to say, but we aimed to create space, especially distal to upper deciduous canine. And then from this point and beyond, she exfoliated the lateral incisor. So we're asking some additional alignments to increase even more the intercanine width. And this was the plan they did based on our indication. This was happening during COVID-19, during the lockdown. So I did not remove the attachment in this patient, but I expanded a little bit more to have room for the lateral incisor. So this is an intermediate lateral X-ray we did for her. And you see at this moment what happened. It happened that the lateral incisor exfoliated, and we have the lateral incisor permanent erupting more lingually. So here you see the comparison before treatment and before additional liners. So what we did in this case, we left, I could have left 6 months or 1 year to have the lateral incisor. What I did, I behaved with a wise approach. So in this case, I removed all the attachment. Once I got enough clinical crown, then I just spent a month and a half at bonded 6 brackets on these lateral incisor with an additional information of torque. And then I went back after a month and a half with aligners just to optimize treatment time. So this error, as you see during the additional aligner stage, and you see that the scenario is changing quite importantly. And this is already at the end of phase 1, almost. You see, this is how she changed it before in progress. Giulio is another scenario of patient that you can have. 9 years old with the crowding in the upper and lower with a class 1. You have deep height, and it's evident that we need space in this case. And this patient was a special need patient. So the strategy in this case was to expand to recover the space required for the eruption of upper canines, use the bite block effect to control the open angle, and the mandibular arch development to recover the space required for the eruption of lower canines. This was the clean check plan. You see that we have a patient with some years even advanced, even more than the first 3 that I show you. Here we got 29 aligners, and you see that we have an eruption compensator in the 22 area. So we were using that space between the central incisor, expanding in the upper arch, and having spaces created, medial, at least typically 1.5 to 1.7 millimeter of space, medial and distal to the situs canines. And you see that the protocol here was transversal, not simultaneous, but permanent molar first, followed by the other deciduous teeth. And after 2 months, weekly aligner change. After 4 months, still weekly aligner change. And the 6 months, this is how it was at the end of phase 1. So at this stage, he went on a sort of standby phase, as you saw in the previous patient, where we only have to wait and see. Wait and see how they will exfoliate these deciduous teeth, how the permanent teeth will erupt, and then having to see if we will need a short phase 2. So just also here to make a comparison, how we got the clinical scenario after 6 months and how it was planned 6 months before in the virtual reality. And the same happened also on the upper occlusal. And this is one of the most rewarding aspects we can see during a treatment with aligners when we see the virtual and the clinical react. The second dimension I would like to cover with you is the sagittal. And in that sense, I want to cover the aspect related to class 2 malocclusion and mandibular advancement. So I hope you saw some scenarios already this evening where you can handle with aligners in a transversal. Regarding the sagittal, Align Technology has embedded, introduced years ago, a specific feature called mandibular advancement. So do we have guidelines and do we have features that can allow us to provide a digitally driven appliance as an alternative to the conventional appliance, which is the twin block? Everybody knows the twin block. Twin block is an excellent appliance. I don't know in Belarus or in Russia, but the country, but in Italy, for example, it's very difficult to convince a young patient to wear a twin block. It's a question of the fact that today in 2020, people know the existence of other appliances. So this was the challenge that Align Technology, for example, had to create an appliance digitally driven, having some of the aspects and features of the twin block. So in class 2 with regard to the mandible treatment, do we have guidelines? Should we provide the treatment when the child is there with transitional dentition as a phase 1 treatment? Can we act on mandibular growth? And should we carry out treatment at only adolescents compensating for skeletal dysplasia? These are all questions that we always have every day. And we know that every time we have a new patient in chair, it's always a question of decision. We have to make a decision. So the Cochrane Library was quoting that the only reason why we should go and treat early is to reduce the incisional trauma, especially in calcium division. But it should not be considered the only reason. There are not only other advantages. Yes, there are other advantages. So we need always to consider the biological timing, and we have evidence here that by O'Brien, by Batista, but O'Brien and Batista did not consider the biological timing of the functional intervention. So we should consider also aspects like what have stated by Bacchetti and Franchi, the vertebral maturation. These are aspects that we should consider, but not only the vertebral maturation. Of course, when you're acting with this kind of appliance on a pubertal peak, they should be even more effective. But this doesn't mean that we cannot use it on an early stage. Orthodontics is not a cookbook, so we know there are some basic rules, but this can be adapted to the patient and to the different scenario. It doesn't mean that will not be effective. In some scenario, will be less effective. In other one, will be more effective, depending on also on some data that I will let you know later on. So there are other aspects that can be used, and this article has been published in 2020 by this Brazilian group. On another aspect we can consider, so the diagnostic assessment of tooth maturation of the mandibular second molar as a skeletal maturation indicator. So there we have tools to identify at which ideal time we should act without treatment. So and we have things. So if I consider Carlotta and social impact on kids, can I improve her lifestyle? Or we say, should I improve the lifestyle? Yes, I can. And I will say I should. Because when I swapping a profile like this with an orthodontic approach, not invasive, and improve it, I think I provide a service to this young population instead of leaving her like this. And where today a young parent is bringing a patient to your practice is asking, do we have a plan B? Do we have a solution which is not the typical orthodontic approach? And can we do it with aligners? So in the treatment with mandibular advancement, and you see here 3 profiles of 3 different patients, and you can see how they changed it before and after their treatment with the mandibular advancement. So there are some indications. Growing patient with retrognathic class 2 malocclusion in permanent dentition or stable latex dentition can be considered for class 2 correction from mild to severe and must have stable E during the mandibular advancement phase. Of course, one of the aspects is to consider the vertebral maturation. So depending on the status, this device will be more or be less effective or will take more time. But also other indicators, and I repeat, is indicators, they're not cookbooks. So if the gonial angle COG-OGN is below 125.5 SHTS3, the patient will react properly to functional treatment. If this value will be higher than this value, the answer will be lower. And if the condyle orientation is vertical, is a favorable sign. If inclined backward, is unfavorable sign. So this paper published on the angular orthodontics in 2017 was making, for example, a comparison of the stepwise versus the single-step advancement with the functional mandibular advancement in class 2 division 1. And what did this group find out? That the group of patients treated with a step-by-step approach was more successful than the ones with the one step. So It's always good that we have these data either confirming or not some investigation. And don't forget that treatment with aligners is still a baby compared with the conventional orthodontics. But if we don't give chance to this baby, I still consider it a baby to be in our practices, then it will still remain a baby. Now, luckily, there are some of us who using aligner almost since 20 years. So for me, it's not anymore a baby. I use it in the not in the vast majority of our practice. There are some cases when I use a hybrid approach, when I have a movement which is going beyond the possibility of the system. But again, I tend to keep an open mind of the different options I have as a weapon in my office. So Carlotta was the case you saw. These was the panoramic findings. So mixed dentition, no missing teeth, normal anatomy with the second molar present, and with the germs of lower third molars. And you can see from the lateral X-ray the huge overjet she got to be corrected. Which was the vertebral maturation stage. She was not at the two-vertebral peak. She was a pre-vertebral. So this doesn't mean that that will not work. The patient will not react. But the question is, should I wait maybe 1-2 years, or should I start at this stage? So the patient and family main concern was this ones, the profile, and you can see from the front view, the not nice smiley Carlotta she got. While we, in the office, which are the main issue in this case? For me, the transversal problem, rotation, and the excessive overjet. And which are the main issue for me? The sagittal problem to solve. This was a clinical plan. When I started, this is one of my first pilot cases. You see that the wings, which apply a functional effect in combination to the orthodontic effect given by the aligners, was not having a pre-MA phase. I did not have this possibility at that time. I had to start from the beginning with the wings and in combination to the ortho movement, but I could not accomplish the full rotation of the molars because I could not place attachment. And this was an improvement in a request we made to align. When I say we, I see all the colleagues involved in the pilot of this specific kind of appliance of the mandibular advancement feature. And this was something we asked it to align, to have a pre-MA phase to make sure we can work on the, for example, derotate molars, expand, and then having those wings, so the functional after a little bit later. So the good thing about this kind of approach is that we have the orthodontic effect and the orthopedic effect. So she started like this. Usually in this kind of case, I document a lot. So having both the picture with and without the aligners and wings. You can see here, this was the first generation of wings, shorter, not so stiff, compared to the one we have today. We have longer wings. And it's important to extract the patient at that age to close the mouth and having those lower wings in front of the upper. Otherwise, the risk is that you have the patient chewing on these wings. So before treatment and aligners in place, how the profile changed with the MA feature inside, and that was an immediate psychological effect on the patient itself, on the mother, on the aunt. So you can imagine the involvement of this patient already from the beginning. The protocol with this kind of appliance was forecasting aligner change every week, 4 aligners delivered to the patient, and then every 8 stages it was forecasted 2 millimeters of mandibular advancement. This was how she was at the beginning, and this is how she was after 3 months, how the profile changed, and this was her after 5 months. You see that progressively we are improving the sagittal, working on the derotation of the upper first molars, working on the transversal. You see that also from the frontal view, this upper arch was not so much collapsed in the intermediate area. And this was at the end of MA phase. You see that in this case, Carlotta, apart from the improved profile, if I look at a dentition, sagittally, I was I was arrived at the home base or where I was planned. So sagittally, I had a class 1, molar and canine. Transversally was improved. You see at this stage, I have already the permanent canine erupted. These two minor space gaps in the bicuspid area was due to the presence of the wings during the treatment, but I was not worried about these gaps because I have to clear these teeth will exfoliate very shortly. So this was a panoramic X-ray at the end of the MA phase. If you remind how much was increased the sagittal, so how much the overjet was increased, now the overjet is much more pleasant than in the past. And we did some measurement at the before treatment, at the after the MA phase, so within 12 months. Look at the data of a COGN 95 millimeter and data 105. The question could be, do we have a growth or we have an increase of the length? So, or it's just a displacement. So we don't have a data yet so large to define which is the response of this number. Probably is a combination of the two aspects. And this will be, of course, a role of more studies. And you will see soon an article published on a journal on a collective study of my cases, Dr. Castafoloro Chiesa at the University of Torino, specifically on the mandibular advancement. These were the superimposition and how the profile change was before and after the MA phase, how the smile was changing before and after MA phase. What about the airways? So we know that we cannot use lateral X-ray for measuring the space. We can do this using CVCTs. But only making a drawing was showing me an improvement of the airways from the beginning to the end of the MA phase. So in summary, we had 42 aligners in the upper and lower arch, aligner change every 7 days, a minor finishing stage, so 12 months of treatment time for this mandibular mountain phase, so a phase 1. Retention, we used Vivera on both arches, and what we did, we just wait and see for the full permanent dentition for an eventual short phase 2. And this is the control of Carlotta after 15 months in a standby phase, where you can see that here in the lower arch, we have the eruption of the first permanent bicuspid. We still have 2 baby teeth to be exfoliated, while in the upper arch, we still have baby canines, baby first molars, and baby second molars. And that's a control of the 24 months and the standby phase. You see that now is in the upper arch. She came to a moment where you have a lot of permanent teeth erupting, and we have space for the first and second bicuspid, and we have enough room for the upper canines, still keeping the sagittal position in place. Anna is another example as a second pilot case. Usually I consider this the first one, while Carlotta the second one. And Anna was 10. And when I saw her at 10, she were with open bite, with a class 2, and with a mild crowding to solve. And you look at how huge was this sagittal discrepancy. So we have a protrusing maxilla, retrusing mandible, open bite, and excessive overjet. What about the vertebra maturation stage? It was still early. It was a prepubertal. But we decided as a good Italian to break the rules, not starting to wait maybe a couple of years. And that was the ClinCheck plan of Anna, where we have 34 upper aligners and 34 in the lower, still without a pre-MA phase. At that stage, we did not have this option. And this was her after 5 months. Very diligent patient. Fitting was perfect during the whole. And both these patients was not living in my city. One was living in UK, and the other one was living like 300 miles away from my city. And look at the difference between the beginning, especially if you look at the overjet, how this was changing over the time. I was using with the scanner to do scans every 3 months to watch, make superimposition with ITERA of the progress assessment. So looking here, the comparison between the virtual and the real, the clinical, so see if the clinical plan was overlapping to the clinical scenario we have at that time. And you see that the majority was yellow. There was only one tooth in green. There was only one teeth in yellow, means it was a minor discrepancy, but still I could keep the treatment with these aligners. And this is very rewarding for the patient because I tend to involve the patient during the treatment. This is heard before treatment and before refinement. You see that the open bite was disappeared. The class 2 relation was improving. And this was before refinement. So before additional aligners, where we have, you see, upper first permanent bicuspid erupti. And this was heard at the end of MA phase. You see, I overcorrected the sagittal in purpose. And you see now, we only have to wait and see. Profile change before and after MA, sagittal correction, and vertical correction, and transversal correction. So here we have the three aspects, the transversal, the vertical, and the sagittal. In this case, would I have gone to a extraction solution? Not in my hand. And at this age. So 34 aligners, upper and lower, aligner change every 7 days, minor refinement. In 9 months, I could get this outcome home. So considering also the involvement of the patient in the active treatment. These are never treatment which are never ending treatment. So retention with Anna went with Vivera on both arches, and we did the same approach. Wait for the full permanent dentition for an eventual short phase 2. And here, standby phase. We have then exfoliation in the upper arch. You see in the lower or almost change it. You see we have a minor class 2 tendency in the 23 area, but we have that space behind that 24 that we can use. From this point, we started a phase 2. You see, the reason why we started a short phase 2 was because of the position of the 13. That was the only element we want to fix. This was the clean check plan that was forecasting 15 aligners, having as aim to correct the position of 13 and improving the setting of the posterior area in the first quadrant. And this is early progress, and this is at the end of treatment. With a minimally invasive approach, midline centered, crowding corrected, the open wall was not anymore there, the class 1 molar and canine, with the second molar fully erupted, the third molar only the crown in formation, and that's at the end. If we look at before and end of treatment, you see the upper is before refinement, and the lower pictures are the one at the end. And the same here. If we look at the comparison, in the upper section we have start of phase 2, in the lower section end of treatment. So in total we have 9 months of MA phase, 2 years of a standby time, and 4 months of a short phase 2. So the total active treatment time for her was 13 months. And 13 months is a very reasonable amount of time. That is, if you see, before treatment, start MA phase, end of treatment after a short phase 2. If I look at this malocclusion, and I think, what if I had only brackets and wire at this stage? Would it be longer, shorter? I typically never tend to do a competition between appliances. Who is the faster? I usually tend to be the most consistent. And this I could bring home with a good protocol. Alessandro is another example of MA. So in the sagittal, this is a special need patient where this patient was allergic to metal, to nickel. We could not handle this case with metal. And this patient with special needs are patients that typically are a very, very compliant patient. So also you're giving also in their life, in the life which is not already so, let's say, lucky, you're giving them an orthodontic experience which is different from the other ones. So you see the maturation of this patient. He was in the pubertal peak, and this was the data from the self analysis. And you see that he was a congenital hydrocephalus with a type 1 bad carry syndrome with a severe mental disability. So drugs resistant epilepsy, so many issues in terms of medical disease. And he also has a typical swallowing with thumb thrust, with adenotonsillectomy already performed. So the treatment plan for him was forecasting Invisalign MA to reshape the arches and reducing the overjet and overbite and class 2 correction. So the treatment duration was 18 to 24 months. And as every time it happened in this kind of patient, the family was highly motivated. So some possible alternative treatment option. I like always to think about alternative. It could have been fixed appliance with class 2 elastics or Herbst appliance, but as I told you, this patient was allergic. Headgear and fixed appliance, again, allergic to metal. No compliance distalizer and aligners and or fixed appliance, or no treatment. This is the clinical plan of this young guy. And you see that here we got a pre-MA phase followed by MA phase with the application of the wings. Typically, you can have different steps. So you have every 8 stage, 2 millimeter of advancement. What you can do when you plan in this case, you can mainly do 2 set of pictures, one in maximum interpretation and one in maximum advancement that you can send to the technician and to give them as a goal for the maximum advancement. This is Alessandro at aligner number 20, 10 days change. This is at aligner 35, 7 days change. And then we have the COVID. So these are the final records of Alessandro, and I have to disclose to thank my good friend Tommaso Castofori and the university, because this is a patient of this group, and you see that the final records of this young patient was quite astonishing, for me at least, to see how committed was this young teenager on using aligners. And these are the final records of him. And if you look at the comparison before treatment and end of treatment, here, sagittally, we got at least for me, I consider this one of the most excellent outcomes we could get with alignment in a special need patient. Imagine you have to deal this with brackets and wire and elastics. That will be, you will sweat a lot to get this outcome, especially when you have typically difficulties on complying on wearing elastics, and that's in this kind of patient. These are the X-rays, and this is how the COGN went from 107 to 115. Guess as the other cases, it was displacement or growth, probably a combination of both. Chiara is another scenario of how you can deal with the sagittal correction with aligners with a different approach. You see that here Chiara had ugly duck syndrome on the lateral incisors, you see, class 2, left and right, midline shifter with some mild crowding to handle. Lack of space. This was a diagnosis summary for her with a skeletal class 1 in terms of width, with a class 2 molar relationship. And here, what did I ask it? I asked it in the upper arch a diagnostic setup showing me in one stage the class 2 correction that I would perform with another appliance, not with aligners. Because I saw that the amount of movement that I have to handle with aligners was quite long, and both the family and Chiara was telling me, doctor, I'm not ready to wear for too long time elastics, and she was very fair. So I said, okay, let's go for a plan B. So we could start with aligners in the lower. I will ask you for some months to wear an elastic using a hybrid approach, and in this case we use a career motion appliance. So I asked the technician after the first clean check, where I got the first clean check plan only with aligners. I modified the clean check plan and I asked the technician, please show me in one stage the sagittal correction I will obtain with another appliance. So that's what you see in one stage happening in the upper arch. You see here, I asked it to place button cutouts from stage 1 on the lower terminal molars. And then I had, you see, attachment present on the lower arch. And in the lower, I had to handle that space in the lower arch. While in the upper, I had only one step simulating in one stage what I will do with another appliance for the first part of the treatment. So I started the hybrid phase with 2 motion appliances left and right, 2 side kick on the lower first molars, lower aligner from stage 1. And after 3 months, I got my class 1 at home. With those spaces present, which is not a side effect, but a natural consequence of the derotation and on the shifting of the segment canine to molar. And Chiara knew that already from the beginning. She was not worried. I said to her, look, when we come to this point, then we remove these devices, do a scan for aligners to handle those spaces. So I swapped to aligners in the upper arch, I did a scan, and then I 3D printed in the office a model the same day. Within 2 hours, I get an S6 retainer to keep frozen the upper scenario until I got aligners in the upper arch. So then I got, after 3 months, a new clean check plan with 15 aligners in the upper arch, 19 in the lower. Not complicated. What I did as a backup plan, I kept 2 cut for elastics on the first molars, deciduous, in case I was missing that class 2 correction done. This is during the issue aligners, but the class canine was kept, so I did not need to ask to Chiara to wear elastics. And that's her at the end of phase 1. You see that at the end of phase 1, I had in purpose asked it to have spaces nasal to the upper deciduous canines to make sure I have enough room for the upper permanent canines. But now, from now on beyond, I just to be wait and see the exfoliation of the deciduous teeth, and then to evaluate if I will need a phase 2 later on, maybe in a couple of years. This is the lateral X-ray with the Ceph I did at the end of the phase 1. And if I make a comparison, yes, I could have corrected the sagittal only with aligners, but here one of the most important aspects was the patient itself. Chiara was telling me, doctor, I'm not ready to wear elastic with a sequential distalization for so long, probably a year and more. So here we went to plan B. And after the end of phase 1, you see that here there was a comparison before treatment, end of phase 1, and how we were accomplishing that goal that we are already in virtual. So as a summary of the treatment for Chiara, we had a hybrid phase of 3 months with additional aligners, so 19, so 6 months, so the progressive aligner change 15 to 10 to 7. So the treatment time was 9 months. So if you're considering 3 plus 6, 9 months of treatment to accomplish that goal from the beginning to the end, that's for me also today in 2021, an efficient and effective way of dealing a treatment. Someone can ask me, oh, but you increasing the cost of the appliance. But you all know that the most important cost in our practice is our time. It's not that spending another 100 euro, 120 or 200 euro will put me in bankrupt. Because then when this case is done, I have room for new patient. So this is where was the clean check plan we had 26. But I show you this. I show you this kind of picture on how you can ask the technician to simulate the elastics, the elastic simulation, different options. We can ask the technician to simulate the action of the elastics either at the beginning of treatment in a clean check, either in progress, so overall the treatment, or at the end. Typically, if I want to simulate a so-called virtual bite jump, I typically ask I show the patient, look, here you see the orthodontic movement. So until here, we will go only with the aligners. That sagittal jump, the virtual jump, will happen only if you're wearing elastics. And this sagittal jump in adults, the literature is telling us this, cannot be above 1.5 millimeters. So this has to be clear that in adult patient more than 1 millimeter and 1.5 millimeter, we cannot expect a sagittal virtual bite jump, while in growing patient you can have more. So Daisy is another scenario, another case that I will show you in this sagittal handling of growing patient. The Daisy is an interesting story because you see this young smiling girl. This is my neighbor living in my house, just the door in front. This was a family who commuted from UK. They knew that I was an orthodontist, so they introduced me to Daisy, and they were, let me say, concerned about the space between the central incisor. When they come to the office, they ask a private conversation with me, and they was telling me, referring an episode of bullying when she was in UK at school. So they asking me, can we, if we need orthodontic appliance, if needed treatment, to not have the typical brackets and wire solution. So these are all articles, 2 articles that is mentioning how effective it could be, and probably also in Belarus and in Russia, you have these episodes. So when she came to the office, I thought it was just a spacing case to handle. No. We have 2 more bigger issues to handle, which was a class 2 on the right side and the crossbite on the right side. So we also, of course, have the lateral incisor rotation to correct. But then I said that we have other issues to correct. So the diagnostic summary of Daisy was a class 2 molar relationship and class 2 canine relationship with a crossbite on right side, deep overbite, excessive overjet with mild crowding on both arches. So it was not only that space, but of course, the minor space was the only thing that they was looking at. So the question was for me, where should I start first? Sagittal or transversal? Transversal or sagittal? And when I had this young patient in my practice, the old dogma I had for many years ago was, okay, transversal first. But think about how effective we are in our treatments in the first 6 months. We know that within the first 6 months of treatment, we can ask whatever we want to our patient. The problem is that after 8 months, 10 months, the patient start to reduce the compliance. So I thought, why I not swap the goals? So first the sagittal and then the transversal. So then if I need to ask the patient to wear elastics, I will ask you the first 4 or 5 months and then no more elastics. Compliance, the 4th dimension, don't forget. So sagittal or transversal. I made a decision to go with the sagittal first. And the treatment choice was lower aligners plus upper motion carrier, shorter time to wear elastics, class 2 elastics during the motion stage, less risky in terms of compliance because it's very difficult that you don't have a patient compliant the first 3-4 months, and a minimally invasive orthodontic strategy. So we have 11 aligners in the lower, for 5 months. This is the clean check, I would say still, the video still. And this is her after really short time. Look at how the sagittal, where I bonded two motion carrier left and right, and I overcorrected in purpose. I said to Daisy, look, you have this space opening even a little bit more, but having the transversal fiber in the upper incisor area working for me to already reduce partially that crowding in the upper incisor area. So after 4 months, that's a scenario we saw clinically in place. Having just a proper appliance at the proper time, sagittal corrected. Yes, I still have the transversal to correct, but already I brought home a good part of the treatment. So I removed the motion 3D. Typically, suggestion is to put having a cotton roll between the two the teeth, and then with an old ligature cutter, just remove this device, and then following steps: the bond motion, provide a temporary extra retainer in the upper arch, and do a new intraoral scan for new lines to complete the phase 1. So here you see that during this additional next stage, there was not so much work to do in this case. We have to give the space, as in the previous one you saw, of having some space mesial to the tissue of the canine to have enough room for the permanent to erupt. And this is at the end of the alignment stage. So where I said to the family, also because I see them every day, I said, look, now it's time to stay on standby. We corrected the sagittal, we corrected the transversal. Now we have to wait and see. And wait and see until we have the whole dentition exfoliated. Someone asked me, what about the effect of the elastics? Only 2 degrees of increase. Don't forget, there are elastics, 6 ounces, quite heavy, but for a reduced amount of time. But very rewarding profile and spine change. So this is covered the sagittal. So the first 2 parts, correct, I hope that gave you already some indication on how to deal with aligners in early dentition, covering the transversal and the sagittal. What about the vertical? We know that in early treatment for crowding and deep bite, we have legends in orthodontics like Tony Gianelli that in his era indicated that the appropriate time to start a treatment was to correct crowding. In most instances, is the late mixed dentition stage of development. So early versus late orthodontic treatment of deep bite. So this is a treatment of deep bite that perverting the permanent dentition leads to significantly more favorable outcomes than pre-treatment before perverting in the mixed dentition. So Sophia, 8 years old, if you look at here, how she was at the beginning, this is a case that I could have left without any treatment. But when you have a young girl like Sophia at 8 years old, the question is, would I leave it like this or can I improve it? And can I use aligners in this case? Diagnostic summary. Skeletal class 3, in terms of width. Class 1 molar relationship with a skeletal class 1 apogonium, skeletal class 1 A and B. And the orthodontic strategy was crowding correction of both arches, deep bite correction, and improve the arch form. This is the clean check plan of Sophia, where you can see that we have 26 aligners having as a goal to correct transversally, to correct vertically. As you see, we have 2 bite ramps on the 2 upper central incisors. Is considered like the turbo bite of aligner treatment. We are working on the derotation of the upper first permanent molars. And here was how we got what we got at the end of the vertical stage. Detail on expansion was showing us an amount of transversal change not that great. As I told you, I'm quite conservative in amount of transversal change at that early stage. But you see that at the stage 14, the vertical is improved with a dental alveolar approach, of course. Stage 21, patient very compliant, very silent, but very compliant. And after 8 months, we got this outcome. With the crowding corrected, without the use of IPR, we have room to procline here, in this case, lower incisors and also upper incisors. And after 8 months, we have a different scenario. Regarding the deep bite management, this is what we got within that amount of time. And this is what is always interesting to see how much you can change with a minimally invasive approach. Of course, I could have used brackets and wire in this case, but the question today in 2021 is why not using a different approach? Why not using a different appliance? Of course, having the brain of the orthodontist is always behind in terms of planning. Because when you plan this and you got this, what does it mean? Is the appliance good or the orthodontic is good? It's probably is a combination. Is that the same as we use in bracket and wires? But the good thing about planning in this case is that you are proactive. So you plan before and you visualize to yourself and to this young girl what should be the outcome within 8 months, 10 months, 1 year. And if I'm looking at the lateral and the central, the same. This was exactly what we planned and what we got home. The same for the occlusal. If you look at the major ridges of the upper incisors and lower incisors, was exactly reflecting what we got in the virtual world. And this is what we got from the lateral perspective. And this is at the end when she ended the phase 1. So she ended phase 1 when we got the lower canine erupting, so having room. So this picture were taken just before removing the attachment. And from then on, then we decided to have the patient going in standby. So as a summary of the treatment of Sophia, we got 25 aligners on both arches, aligner change every 7 days, short refinement stage. Refinement is the so-called finishing and detailing phase that we always have in aligner treatment, as we got with brackets and wires. So in 8 months of treatment time, phase 1, we use Vivera retainers on both arches, and she is in the standby phase for an eventual short phase 2. Actually, she just started the short phase 2 that she will last for almost 6-8 months, not more. But we went through a couple of years of standby time. So you saw a case of deep bite. Alessia is another scenario of not deep bite, but the other, almost an open bite, especially on the lateral incisor area. She came here with not a good hygiene. You see by cavities on the deciduous dentition, with spacing in the upper and lower arch. And look at these canines in the upper arch. We were not in a favorable position. So here we decided to go with an Invisalign first approach. You see in the ClinCheck plan, we were forecasting 33 aligners in the upper and 28 aligners in the lower. We asked here to expand, to get room for the permanent canines here, especially in the upper right side. You see that here, in this case, I became more brave in the transversal, so 6 millimeter of expansion in the upper and lower arch. And this during treatment, you see that here I wasn't worried about the exfoliation of the baby teeth because then I have the eruption compensator present on the permanent tooth. You see that now scenario is improving, and these are before additional aligners. We did not have any more open bite here in this case. We get a new set of aligners. Don't forget at this stage, at this age, you're changing an aligner every week, sometimes every 5 days. And this was the additional aligner stage where we just completed the position of the lateral incisors, having still the room for canines. This is not a big cleaner, but you can imagine if we were using brackets and wires in this patient with a not super hygiene session. She became better over the time. Then here you see midline centered, spaces mesial and distal to the deciduous canine, and see that now in the upper, in the second quadrant, we have the permanent canine almost coming out. So at this stage, you see before treatment, at the end of phase 1, we decided to stop phase 1. Before treatment, end of phase 1, and look at the parallel X-ray before treatment at end of phase 1. That's a different scenario, definitely, that we have within less than a year. Electra is one of the last scenarios I want to share with you too. You see here, we also have an open bite tendency. Crowding, high angle patient, potentially difficult to handle. You see that she got a class 3 in terms of widths, class 1 with open bite. ClinCheck plan for her was forecasting 25 upper aligners and 20 lower aligners with all the attachment placed by the technician following my prescription. And you see those spaces, especially in the upper first quadrant, to get room for the permanent canine. This is during treatment. Before the additional aligners, you see that here, during treatment, we have those eruption compensator and the aligner itself as hosting room for the permanent teeth coming out. We have a new set of aligners, 16 and 15. You see the eruption compensator in the second quadrant. Minor transversal movement. Typically, you saw in all these cases, mainly I don't do interproximal reduction. And when I see a ClinCheck with 0.2 of IPR, in the majority of scenarios, I don't need to do it clinically. These are in progress. And now, this is a case where mainly you have then to wait and see. So before treatment and end of phase 1, an open bite case in early dentition with a limited intervention by the orthodontist with a minimal invasive also approach. We have now more room for the permanent canines. And if you look now, scenario is not that complex to solve. So this are in standby after 10 months. After 10 months, you can see that now we're just waiting and see. Most likely, this patient will not need to have a phase 2, also short, because we have some minor rotation on the lower second bicuspids. We have those spaces that we will manage by losing anchorage. But now you see that this is a scenario where most likely I will not need, at least now, to ask the family and her to go for a new part of the orthodontic treatment. So with this kind of approach, we have a very limited amount of intervention within a year, and then leaving then the whole environment adapting to the new scenarios. So what about the future in early treatment with aligners? Do we have new options for growing patients with aligners? I hope that tonight I show you some of the options in the 3-dimension. We saw the transversal with Invisalign first. We saw the sagittal with mandibular advancement. We saw hybridization with aligners and motion carrier. And we see how you can handle either both deep bite and open bite in growing patient. But we have options, and we have what is missing in all this. There is still one, let's say, appliance that we don't have yet in the aligner industry, in the aligner world. But if you go on Google patent, you see that there are already some patents which has been deposited about one appliance that what reminds you, expander. So imagine in the future having an expander, not in maybe metal, maybe an expander that is maybe thermoactivated, that could work in combination with aligners. such as we have today in the sagittal, where we work with aligners and wings, having the orthopedic and the orthodontic approach. So maybe we will see this in the near future. But as I always say during my talk, the evolution is one of the most fascinating aspects of our profession. And I always like this quote because the past is behind and we have to learn from it. And I learned a lot in these last 20 years on using aligners. I made mistakes, I learned from mistakes. The future is ahead, so we have to prepare for it. But the present is here, live it. So what does it mean? That typically every orthodontist is impatient. So we always want to have what we don't have yet. But we have to be patient and use what we have today. And we have a lot of things. Trust me, after 20 years, when I did my first case with aligners, and that was another patient, we didn't have all these features, protocols, materials, and softwares that we have today. It took time. It was a challenge for me. Someone called me an innovator. Someone told me early adopter. It of course was a challenge, but in life we live once, and I really usually like. I rather taking some risks sometimes, but since we live once, I like to do things and also to act differently. And sometimes is a challenge that you can do and you win, but you have to work hard. You have to work hard in planning. You have to work hard in monitoring your cases to get the success that you deserve. So, as I always say, I usually try to stick on time during my talk. I bring the salute of my city, which is Torino, which is located northwest in Italy, very close to Milan. Is an ideal city because it's 45 minutes from the sea. We are 45 minutes from the Alps. You see that we have the Olympic mountains of the Winter Olympic Games in 2006, and then we are 45 minutes from the lake. So we have a river, and Torino is known for typically cars, for soccer teams, for Cristiano Ronaldo. So recently, in the last 3 years, and he lives almost. I can see him house from my kitchen. But we have a lot of energy. So it's a city that is considered very energetic, innovator. I have the luck to work close to the university in Torino with my good friend Tommaso Castroflorio, who is almost a brother to me, and we share a lot of ideas and plans and projects. So if I can make a recommendation for my colleagues in Belarus, in Russia, in all parts of Europe, network. Network is probably the future of our profession. So say that, I thank you so much for your attention. And if there are any questions for me, I'm here available to answer your question. Thank you so much. Thank you so much. I hope that really, probably if there will be some questions after the webinar, I will ask the team to send it to me. But I think there is, especially for those of you who are not yet in the aligner world, you just have to digest information. But really, from my point, I really hope that at least, as I always say, you bring home at least one or two tips to embed in your practice. Thank you so much.